Hello friends, welcome to our channel Easy Micro. In our channel Easy Micro, we will explain all the topics of microbiology in an easy manner. So once you watch this video and then you read the apurba shastry book, then it's more than enough and you are prepared for the exam. So without being late, subscribe our channel fastly. Friends, the topic that we are going to discuss now is intestinal amoebiasis. So first of all, let us look how the examiner going to ask the question in examination. So if the examiner gives a clinical question saying like the patient has suffering from bloody diarrhea with mucus and pus cells, then blindly fix that it is a case of intestinal amoebiasis. So after that, now let us look how the examiner going to ask the subtopics. So what are the subtopics that the examiner going to ask related to intestinal amoebiasis in examination? First topic which is being asked most commonly and frequently is life cycle and morphology. And later on the second topic is pathogenesis, which is the most important one, clinical manifestations and lab diagnosis, and also the treatment. So now let us discuss all these topics now in this video. First topic which we are going to discuss today is morphology. Entamoeba histolytica has three stages in its life. First stage is the trophozoite, which is an invasive, replicating and feeding form. And the second stage is precyst, which is an intermediate stage and it doesn't have any importance. And third stage is the cyst, which is most important form. It is an infective and diagnostic form. And cyst is an important in lab diagnosis. And cyst has 4 nucleus, so it is called as quad nucleated. The next topic is life cycle. So the Entamoeba histolytica completes its life in a single host, that is man. And the infective form, like I said before, it is cyst, which has 4 nucleus. And mode of transmission is through contaminated food and water, that is fecal-rectal route. So now Entamoeba histolytica enters our body through contaminated food and water, and then the cyst is so strong, so it bypasses the gastric juice and then reaches the small intestine. Now let us see how it develops in the small intestine. Now let us see the development of Entamoeba histolytica in small intestine. First of all, let us see a small brief about the life cycle. So let us start the life cycle at the infective form, cyst and the host man. So once the cyst infects the man through the contaminated food and water, then it bypasses the gastric barrier and reaches the small intestine. In small intestine, the cyst exits the cyst form and transfers into the trophozoite. And later on, these trophozoites reaches the large intestine. In large intestine, the trophozoite has the 3 options. The first one, and which occurs in majority of the individuals, is it doesn't cause any lesions and the patient will be as asymptomatic cyst passers. And in some individuals, it causes the amoeboic dysentery by adhering to the intestinal mucosa. And rarely it causes the invasive amoebiasis. In people, in that people, it invades the intestinal mucosa and migrates to the extra intestinal sites like the liver and causes the liver abscess. So once again, let us look what happens in majority of individuals. So in majority of the individuals, the trophozoite reaches the large intestine, and then the trophozoite undergoes the encystation. Enters the cyst form, and then it is released through the feces, and which acts as a infective form. Now in Sometimes the trophocytes are also released along with the feces, but the trophocytes aren't resistant to the environment, so these trophocytes will be disintegrated. Now, let us discuss the virulence factors. Virulence factors mean the factors which causes the pathogenesis are known as the virulence factor. The first one is gall-gallinac lectin. Gall-gallinac lectin is an principal virulence factor. It helps the entamoeba to bind to the glycoprotein receptor present on large intestine. The second one is amoebopore. Amoebopore helps in the formation of pores. Amoebopore helps in formation of pores. And the third one is enzymes. So enzymes like 16 proteases and metallocollagenases helps in the hydrolysis. Now, let us see how these virulence factors are going to cause the pathogenesis. So, first of all, these trophocytes colonize in intestinal mucosa. I mean, they will increase their number, which becomes easier by the help of bacterial flora. After their increase in number, they simply adhere to the intestinal mucosa by the means of gall-lectin molecules and penetrate the mucus layer. After penetrating the mucus layer, they form the characteristic flask-shaped ulcers. So these ulcers are most commonly seen in the cecum, and they occur as scattered with intervening normal mucosa. I mean, normal mucosa, ulcer, normal mucosa, ulcer, normal mucosa, ulcer. In this manner, they are scattered with the intervening normal mucosa. So rarely, these trophocytes will invade the extraintestinal sites. Most commonly is the liver by the help of the cystine proteases and causes the liver abscess. Now, let us discuss the clinical manifestations. The incubation period varies in different individuals differently. So, it varies from 1 to 4 weeks. Majority of the individuals doesn't show any symptoms and be as asymptomatic. So there will be 90% of people are asymptomatic, and remaining few 10% people will show the symptoms such as amoebic dysentery. So in amoebic dysentery, the patient suffers with bleed diarrhea with mucus and pus cells. The next symptom is amoebic appendicitis. So, in amoebic appendicitis, amoeba infects the appendix and causes acute right lower abdominal pain. Our next symptom is amoeboma. Amoeboma is nothing but the palpable abdominal mass which occurs in the large intestine. And the last symptom is fulminant colitis. During fulminant colitis, the patient suffers through intense colic pain and more than 20 motions per day. The topic which we are going to discuss now is laboratory diagnosis. So, like I said before, if the patient suffers from bloody diarrhea with mucus and pus cells, simply it is an intestinal amoebiasis condition. So, first, what is the specimen of choice? Obviously, the specimen of choice is nothing but the stool. So, minimum 3 stool samples should be collected on alternative day because amoeba shows the intermittent shedding. So now we collected the stool sample. Now let us examine the stool sample by wet mount and permanent stain. Guess what we found? So we find the cyst and trophocytes in the stool. So we identify the cyst by the presence of 4-nucleasin, and we identify the trophocyte by the presence of finger-like pseudopodia in it. And then If the specimen is not stool, if the specimen is the intestinal biopsy, then what will we do? So then we'll stain it with the pus and H stains. Guess what it reveals? So guess what we find in intestinal biopsy? In intestinal biopsy, we only find the trophozoite. And then now let us see, we got the stool specimen and now we have to culture it. So we use the two kinds of media here. One is polygenic and another one is the axenic. So what is polygenic? What is axenic? Polygenic, poly. So in name itself indicates that it has something additional. So the polygenic media has the bacterial supplement. So why bacterial supplement mean? So when the parasite dose is so low, so when the parasite dose is low, we give the polygenic culture, because since we parasite dose is low, we say to the parasite like take this bacteria, eat this bacteria and get stronger and grow more so that we can find you. So the polygenic media has additionally bacterial supplement. When it comes to the axenic culture is pure. It doesn't have any bacterial supplement. So the example for axenic culture is diamond. So diamond culture. So diamond pure होता है ना. So diamond will shine pure. So the diamond is an example. Diamond culture is an example for axenic culture. Now it goes very easily from here. So the stool antigen detection or amoebic antigen detection, amoebic antibody detection. So everything. So these three things are done using the ELISA. Stool antigen detection and amoebic antigen detection and amoeba antibody detection is done through the ELISA. And then the finally molecular diagnosis is done using PCR and real-time PCR. Now we have successfully completed the lab diagnosis. Finally, now let us discuss the treatment. So in asymptomatic individuals, in whom the trophozoite are inactive, we treat them with the luminal agents like paramomycin. And in the amoebic dysentery patients in whom the trophozoites are active, we give them tissue agents like metronidazole for 10 days along with the luminal agents. And other factors or other measures that we have to take are like fluid and electrolytes replacement, because it is diarrhea na, so many fluids and electrolytes will be lost, and symptomatic treatment is also preferable.
और अगर तुम लोग नए हो तो सब्सक्राइब करो, वो जो लाल वाला बटन है इस पे फूट फेंक के मारो या फिर मोमबत्ती, मुझे नहीं पता, बस क्लिक हो जाना चाहिए। हम करते हैं, अगर तुम्हें वीडियो पसंद आई तो लाइक मारो यार, मुझे नहीं पता, मुझे 2 मिलियन लाइक्स चाहिए, कैसे ना कैसे करके मुझे चाहिए। इतना चिल्ला मैं कभी नहीं होऊंगा अपनी पूरी जिंदगी में जितना इसमें चिल्लाऊं, मुझे चाहिए ही चाहिए, तो लाइक मारो।
जय हिंद दोस्तों।